خلاص الحين احنا لايف على اليوتيوب. الحين بدخل الجميع للتندي. ها بسم الله.
انت حتسوي ريكوردينج يا ظافر؟
بدا التندي يدخلون.
مظبوط صح. التسجيل وصل 1600 ما شاء الله.
طيب خلاص ما شاء الله حضور. ممكن تبدا دكتور معاذ.
سم
تفضل خلاص ممكن كان ستارت.
بسم الله الرحمن الرحيم، الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, good evening this night. On behalf of the SASPGHAN, the Saudi Society of Pediatric Gastroenterology, Hepatology and Nutrition board member, we would like to welcome everybody to our webinar. This is the single topic webinar series. Today is the second webinar about the metabolic liver disease. Tonight we have three distinguished speakers. The first one will start with Dr. Dhafir Al-Shehri, who's the assistant professor of pediatrics and pediatric gastroenterology, and he's the chairman of the pediatric department at the College of Medicine at the University of Najran. Dr. Dhafir will share with us case discussion, and after that we'll have the discussion. Then after that we'll have some questions. Then the second speaker and the third speaker. Welcome, Dr. Dhafir, and you can start now.
Thank you so much, Dr. Muad. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. I would like to thank the organizing committee of SASPGHAN, which is the Society of Pediatric Gastroenterology, Hepatology and Nutrition, for this organizing this webinar. Today I will talk about this case. I will start with this case as introduction for our webinar tonight. This is a 3-month-old boy, product of full-term pregnancy with a spontaneous vaginal delivery. He was referred to King Faisal Specialist Hospital and Research Center as a case of acute liver failure for further management. His presentation actually started 10 days prior to admission, which has circumcision complicated by bleeding. He went to the private hospital in Riyadh, and they control the bleeding with the suturing, developed later on hematoma, and start to have urea, fever, and scrotal swelling. Then he has abdominal distension and, as I mentioned, scrotal swelling. So was admitted, and initially there is no history of jaundice, itching, diarrhea, or constipations, and also there is no decreased activity or decreased oral intake, no weight loss or vomiting. His initial lab results at private hospital showed he was anemic, and also in the platelet in the lower side, 115. With prolonged with coagulopathy and INR of 9.7, which not corrected by vitamin K. Liver enzyme, as you can see here, considered mildly elevated, but coagulopathy he has. He has elevated alkaline phosphatase more than 2400. Renal profile and electrolytes in addition to glucose was normal. Upon examination there was murmur, so echo was done, which showed small ASD secundum. Ultrasound also done, and there was significant, there is edematous scrotal sac with the cyst noted at the head of right epididymis. Abdomen CT also was done, which showed massive ascites and enlarged both kidneys. Going back to his past history, as we mentioned, he underwent the circumcision, and the manifestation start after this circumcision. Regarding family history, the parents were first-degree relatives. There is history of one abortion in the first trimester with no apparent cause. He has older brother, 3-year-old, healthy. There is no family history of metabolic or liver disease. He received upon delivery the birth vaccine of hepatitis B. So his vital signs in our hospital, King Faisal, the temperature was 37.7, heart rate was 130, respiratory as well was 50, blood pressure 90/53, and oxygen saturation was maintaining in room air. Physical examination, generally he looks well. He was well hydrated, mildly jaundiced, but there is no distress and no dysmorphic feature. CNS was grossly intact, he was active, anterofontanil was open and flat. Cardiovascular was normal. He presented to us after 10 days of admission at private hospital. Cardiovascular normal, respiratory, abdomen was distended, and we cannot actually appreciate the organomegaly as severe ascites, which was positive. Genitourinary examination, there was bilateral scrotal edema and penile hematoma. Musculoskeletal and eye exam were normal. His lab results in our hospital showed anemia and thrombocytopenia, and coagulopathy. PT was prolonged, 85 seconds. INR was elevated, 6.6, which also not responding to vitamin K. Other chemistry and renal function was okay, apart from mild elevations in the total bilirubin, which was 60. But also, as you can see here, the liver enzyme is not elevated or considered mildly elevated comparing to the coagulopathy he has. Ultrasound abdomen was done, which showed mildly echogenic liver parenchyma and coarse echo texture with a slight nodular line, but there is no hepatomegaly. There is mild nephromegaly with increased echogenicity, predominantly centrally, and medium-sized ascites. So please, if you can allow me to make this session more interactive, you can please scan this code or go to this website and enter this code. And okay. So as you can see here, I need you to answer this question. So what is your wait. So what is the your differential diagnosis? You can write down the answer, and it can be shown here. If you could answer, please. You can write down the, okay. Transamnesia with mild deficiency, transaminasis, severe coagulopathy. Can you give us the diagnosis, please? GI bleeding. What is the differential diagnosis? Gout, okay. Gestational alloimmune disease. What else? The participant more 1,000. Please, okay. Transamnesia, bleeding, okay. Gout, later, okay. Other than gout, Tyrocinemia, excellent. Tyrocinemia, excellent. And gout. What else? Go by common. Okay, Mitochondriopathy, excellent. No idea, maybe, okay, excellent. Mitochondria, okay. Okay. So next questions, because of for the sake of the time. What investigation you need to do more to reach the diagnosis? You can write down the answer, please. You can go to this website, www.menti.com, and enter this code. Directly, you will go to this web page, and you can write down your answer. Liver biopsy, okay. But with the coagulopathy, can you do liver biopsy? Okay, Wes. Whole exome sequence, endoscopy, not in the time being. No benefit of endoscopy in the time being. What else? Some of you say GALT, some of you Terracinemia. Okay, urine organic acid for succinyl, excellent. And amino acid profile, urine succinyl acetone, excellent. Serum cover, seroplasmin, no, it will not be helpful. As the if you think that it's Wilson, unlikely to be Wilson. Never be Wilson actually, because Wilson it will take long time to start, at least beyond 5 years. What else? What investigation you need to do? Liver hormones. What do you mean by liver hormones? Okay, you mean alpha fetoproteins? Maybe, excellent. Serology. Okay, West again. What else more? CK, cortisol level. You can submit multiple answers. LTST already done. Okay. Okay, so we'll go back for our presentation. Thank you so much for this participation. Okay. So the differential diagnosis for this case, initially sepsis, because patient was having fever and also coagulopathy. Sepsis can present it like this picture as well. Galactosemia and Terracinemia also. This is one of the differential diagnosis. Also HLH, okay, which is hemophagocytic lymphohistiocytosis. GALT, your colleague, they mentioned some of you, mitochondrial hepatopathies and others. But this is the main symptoms of or main differential diagnosis for this patient. Okay, so according to our differential diagnosis, we did the following labs, which showed there is a positive culture from the benign hematoma and ulcerations, showed growth of Klebsiella pneumoniae, and initially was treated with tazocine and vancomycin. GALT, which is galactose 1-phosphate uryl transferase. This is it was sent and it was negative. Ferritin was done, it showed 580. This is sometimes marker for HLH and also for GALT. Fibrinogen 1.2, which is considered normal. This is also some criteria for HLH. Triglyceride 0.7. Lactate 1.7, considered a bit normal. The alpha the lactate, it will give us a hint about the mitochondriopathies. Alpha fetoprotein was elevated, more than 60,000, 500. Factor 5 was a bit low, and factor 8 was normal. Tandem MS was sent, which showed methionine level of 266 micromole per liter, which is elevated. The tyrosine level as well, elevated more than 200. It was 369. The most important thing, the urine for succinyl acetone, it was high. So the diagnosis is Tyrosinemia type 1. I'll talk briefly about Tyrosinemia type 1, and I'm sure Dr. Prof. Zuhair will also come back. This disease is inherited as autosomal recessive disease. the mutation happening in the formal acetoacetate hydrolase gene, which is located in the chromosome 15. It's responsible for production of the fumarate acetoacetate hydrolase enzyme, which is responsible for degradations and one of the steps of degradations of tyrosine. Deficiency of this enzyme lead to accumulation of fumarate acetoacetate and the accumulation of tyrosine and its metabolites in the liver, kidneys, and central nervous system. As you can see here in this scheme, this is the tyrosine metabolism pathway. Start by phenylalanine, okay, which is considered essential amino acid. It will give us tyrosine by this enzyme PAH, which is phenylalanine hydrolase. Tyrosine per se, it can cause keratitis, so the patient of Terracinemia, it can present also with eye manifestation. The problem in the Terracinemia actually in this enzyme, which is fumarate acetoacetate hydrolase, which converts also the pathway to fumarate acetoacetate and succinate. If there is defective in this enzyme, so there will be accumulations of fumarate acetoacetate, and actually it's toxic. It can cause the liver and renal damage symptoms. This one also, it can be converted to succinyl acetoacetate, and eventually with succinyl acetone, which resulting in renal Fanconi syndrome and porphyric crisis, as well as CNS manifestations. And these compounds actually, it's considered producing free radicals, which can later on causing malignancy or hepatocellular carcinoma. So the signs and symptoms of Terracinemia, the patient will present with failure to thrive, sometimes diarrhea, vomiting, jaundice, mainly cholestatic type. The urine color, urine smell, it looks like cabbage-like odor. This is one of the manifestations of the Terracinemia. And also the patient will present with coagulopathy as this patient. The Terracinemia type 1 mainly affect the three organs mainly, liver, kidneys, CNS, but it can affect also the eyes. Liver, it can cause cirrhosis and also hepatocellular carcinoma. Renal, as I mentioned before, it can cause renal Fanconi syndrome with amino acid urea, proteinuria, phosphaturia, and hypophosphatemic rickets. The diagnosis of Terracinemia, the main pathognomonic things is urine for succinyl acetone will be elevated in urine. There will be elevated level of tyrosine in the blood, and coagulopathy, and also high alpha-fetoprotein. The management for such patients, first of all, we have to restrict the dietary containing phenylalanine and tyrosine. And there is special form specific for the infants called the Tyrex or Tyros. Avoidance also of catabolic stress such as infection, surgery, and fasting, which can cause elevations of tyrosine and phenylalanine. And also there is some medications, it's long name, but fortunately there is specific abbreviation and it's famous by its abbreviation, NTBC, or registered mark as nitisinone. Patient receiving this NTBC, they will respond more than 95 from renal and also liver damage, but they need actually frequent monitoring, including GLFT and urine succinyl acetone. And also they need ophthalmic evaluations because this medication can increase risk of corneal crystals. Also, we should monitor serum alpha-fetoprotein every 6 to 12 months, in addition to abdominal ultrasound, looking for any nodules because risk of hepatocellular carcinoma. This medication, NTBC, can decrease risk of hepatocellular carcinoma if started early. But also, we need to monitor this case frequently. The NTBC actually it works at this level, okay, and prevent the accumulation of toxic metabolites. So sometimes patients have elevated tyrosine, but cause eye manifestations only. So to back to our patients, patient was managed with special formula as started NTBC with dose of 1.5 milligram per kg per day. Follow up after 3 weeks, he is doing fine. The ascites become better, and the benign hematoma resolved, fortunately. And this is the bilirubin level. Upon admissions, it decreased until normalized within almost 1 month. Also, the coagulopathy normalized and no more coagulopathy. Thank you so much, and maybe you can open the
Thank
question.
you so much, Dr. Dhafir, for this nice case, really. And now we can leave the questions by the end, if you like, Dr. Dhafir, if we can move.
No.
Now the second speaker is Professor Zuhair Rahbini. Professor Zuhair, he's a professor of genetic and metabolic at Al Faisal University. Professor Zuhair also is the founder of the fellowship program, training program of genetic and metabolic at King Faisal. And he has a lot of publications and also, expert in all of the, varieties of the genetic disorder in Saudi Arabia. We are glad that to have Prof. Zuhair with us tonight. Welcome, Prof. Zuhair, you can start now.
طيب بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. مادي باين
دكتور بس حطها على لا بيج سلايد اللي كنت حاط بس فول سكرين بروف زهير
الآن.
ايوه
طيب بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. First, I would like to thank the GI Society, for the Saudi GI Society, for invitation. Thank you, Dr. Muad, for nice introduction. Thanks for Dr. Dhafir and Dr. Al-Mahedi for invitation also. I was given this talk, Common Hepatic Storage Diseases in Saudi Arabia. So I will try my best to expand it a little bit to involve generally the metabolic liver diseases. طبعا I want to say يعني this talk يعني basically is 50% you will find it in literature and maybe 50% from the many years experience in the fields of metabolic diseases. If I want to talk about metabolic diseases and GI, I want to say يعني we are working like this bird with two heads يعني working together. They consult us, we consult them, so we work together all the time. And to show you the interest in metabolic field and GI, I published this paper, one of the early paper with Dr. Nader in 1994 about cystic fibrosis and liver disease in Saudi experience. And we found out liver involvement in Saudi patient with cystic fibrosis is almost 25%. I am glad really this paper found like reference in many literature in cystic fibrosis in Saudi Arabia. So my topics, I will discuss one case, introduction, pathogenesis, statistics, inherited metabolic diseases and liver, some investigation and summary. I will not take long time with this case because I felt that it is the same case that was presented by Dr. Dhafir. So this is, I won't briefly go, but I will add some things. So I saw this patient recently when he was 16 months of age. And basically, I think he is the same patient that presented by Dr. Dhafir he was referred at 10 days or 7 days of life with the liver impairment and thrombocytopenia. So I will not take time. He was a little bit jaundiced, but there is no other thing in examination. Investigation was basically abdominal ultrasound was normal, cranial ultrasound was normal, skeletal survey was normal, MRI was normal, except the things was mentioned by Dr. Dhafir. As you see, the platelets was low and improved with the time. And also the bilirubin was very high and improved after starting the treatment. Also the liver enzyme, as you see, the alpha fetoprotein was elevated and improved. Also the BT, BTT, INR improved. So the diagnosis was reached by finding succinyl acetone in the urine, and we started the NTBC in early life. And this is confirmed by mutation analysis. If you see the patient has homozygous pathogenic mutation in FAH gene, the gene is related to this enzyme. And just as follow-up, maybe Dr. Dhafir, he left before he continued to see this patient. So you can see how his weight and height improved with the time on NTBC. So this is basically a case of tyrosinemia and treated. If you miss this case, the patient will progress to liver failure, and he will die if you don't diagnose these cases early. So if I want to talk about metabolic liver disease in general, as you know, the liver is big organ in the abdomen. It has like more than 70 function. Anabolic, catabolism, many things. Nobody can live with function of normal function of the liver, and the anatomy is unique of the liver. Maybe Dr. Musa will talk more about the histopathology and this, but as you see, the blood supply of the liver coming from two sources: the artery itself with oxygen, and the portal vein that supply a portal vein, that hepatic portal vein that bring the nutrients from the GI tract, and all this blood mixed in sinusoid here for filtering, anabolism. And there is two cells here, as you see, Kupffer cells here, and hepatocyte that do many functions. If I want to speak about pathogenesis, so we have two groups here. Either, all this is related to mutation that lead to abnormal protein. So one kind of protein are transporter. So all this protein in the hepatocyte cell, wall cell, and also in the other side where go to bile acid canaliculi, all this transporter. So if there is mutation in the gene of that transporter, like this gene, for example, BSEB gene, if there is mutation, instead of bile goes to canaliculi here, reflected by to hepatocyte and cause toxicity. The other form is inherited metabolic diseases. So here the mutation in protein that are enzymes. So if there is mutation here, you will have abnormal enzyme or absent enzyme, and you will have block here, and the block leads to accumulation of substrate and deficiency of products. Just this is different topics, but as I have said, all this transporter related to different diseases, many diseases, liver diseases that are genetics in source. Like, for example, if there is mutation in this protein ATP or this gene ATP7B, the patient will present with feature of Wilson disease and other genes, as you see, that can cause Bific 1 or Bific 2 or Bific 3 and so on. So if we want to speak about liver and metabolic diseases, liver involvement is the presenting feature of many inherited metabolic disorders. So inherited metabolic disorder manifests as hepatic syndrome. And it is difficult really to distinguish them from acquired condition like infection and intoxication or neoplasm. So if the patient presents with liver failure, you cannot say is it metabolic or not, because if there is hepatocellular dysfunction related to, for example, metabolic or non-metabolic disease, you will find all this metabolite increase. The patient will have elevated tyrosine, methionine, elevated lactic acid, frequent hypoglycemia, hyperammonemia. So you don't know really if the patient presents with liver failure, is it the primary disease, was it metabolic or non-metabolic, like infection or other causes. So you have to go, so this is just example. There is hepatorenal tyrosinemia will lead to liver failure. However, liver failure, from regardless of the cause, will cause also elevated tyrosine. So you don't know, is it tyrosinemia or not? The only way to diagnose it, you have to go to succinyl acetone. So this is patient with tyrosinemia. You will see elevated tyrosine and all this other metabolite related to elevated metabolites from liver failure. So you have to go and to do succinyl acetone, which is a specific metabolite for tyrosinemia. If we want to see what is the metabolic defects and the liver involvement, actually, this is sad really. There is no national genetic and birth defects registry till now in the kingdom. However, I am glad that there is a committee in the Saudi Council and they started to build the registry, and maybe after a few years you will find good statistics about metabolic diseases in general and maybe liver involvement in these disorders. However, we can get some data from different programs like newborn screening program. If you see, this is pilot study till it was published, established the program by royal order in 2005. So the incidence for 17 diseases, those are the 17 diseases, is one affected newborn among 1,000 delivery newborn. So if you just imagine, one affected among 1,000. So if we know the newborn delivery or newborn statistic by year is 500,000 to 600,000 newborn. So if you just make a simple calculation for 17 diseases, that means 500 newborn to 600 newborn affected with the one of these 17 diseases. So this screening doesn't include other like Bific, like other genetic liver disease. So just imagine if we expand these diseases, how many baby will be affected with the metabolic liver or genetic liver diseases. If you see the HMG coalase deficiency, most of these involve liver. This is organic acidemia or amino acid disorder. And I am glad also to show you this paper, which published recently in 2021, looking for hepatic manifestation of HMG coalase deficiency in Saudi patient. Dr. Sinan Hawaldar was the principal investigator. He was fellow at that time, and we were able to publish this paper. So we look for 50 patients with HMG coalase deficiency, and we found 17 patients. So almost the third of patients, they have liver involvement. And if you look to this paper, it is published already. We found that hepatomegaly was found in 65% of the patient, and abnormal biochemical profile in the form of elevated liver enzyme is about 50% of cases, and abnormal imaging of the liver is almost also in 53%. So liver involvement is if somebody missed the diagnosis by newborn screening, the patient might come to the gastroenterologist with hepatomegaly or liver dysfunction or whatever. So you have to think about also of this metabolic disorder in your differential diagnosis. Statistics from stem cell transplantation in our hospital, I have this data till 2015. Most of these presented with also liver involvement, osteopetrosis, till Hunter or storage diseases. And we had at that time 105 patients that diagnosed with genetic disease and treated with bone marrow transplantation. Lysosomal storage disease is part of this lecture, as you see from the title. We have almost 90% patients now with different lysosomal storage disease, and all of them, actually, all of these lysosomal, they have liver involvement from Gaucher till Wallman disease. This paper published by Dr. Idrisi from Aramco, and you can look for the, it is about cholestasis, neonatal cholestasis, and he looked for different causes. As you see, most of those causes are genetic or metabolic. So router disease, Dobbin, Tyrosinemia, Bific Type C, galactosemia, bile acid synthetic defects, and peroxisomal disorder. So you need in this country to consider genetic/metabolic diseases for any patient referred with liver disease. You can see here Bific is the most common. This is an Idrisi publication, 25% Bific, and he found, I don't know, Reuters and Dobbin Jensen is common in the Eastern province there. However, you can see different causes related to genetic also and metabolic. So if I look to experience for these diseases, liver involvement in metabolic disorder, if you have a patient, you have to look for this issue to consider metabolic. Family history is very important, especially if there is autosomal recessive pedigree in the family. Most of our patients in metabolic presented with conjugated hyperbilirubinemia, so it is more common than unconjugated in metabolic. So if you have patient with conjugated, you need to consider metabolic disorder. Hepatomegaly is persistent and progressive and not tender, like it is soft in glycogen storage disease and hard in tyrosinemia. So if you leave the patient and you palpate the liver every time in the clinic without treatment, you will see the liver is progressive because the metabolic is continuous process without treatment. Splenomegaly maybe coexist basically because of portal hypertension and maybe involvement of reticuloendothelial system. So this is the pedigree in this diseases, autosomal recessive. You will find the transfers affected, generation, boys and girls affected, and there is consanguinity marriages. If I go to the classification and liver involvement, basically, this is the simple pathway. Substrate converted to product in presence of enzyme, coenzyme. So if there is deficiency here, substrate will be accumulated and product will be decreased or deficient. So if you look to the classification, actually there is no international also existent or agreed classification of inherited metabolic disorder. However, people they classify it depends on substrate, for example. So if there is accumulation of mucopolysaccharide, they will call it mucopolysaccharidosis. If it is glycogen, they call it glycogen storage disease, and so on. Or the insight on the site of the defects. So if the defects in mitochondria, they will call it mitochondrial disorder. If it is in lysosome, they will call it lysosomal disorders. Or if there is deficient products here, and this is happening in urea cycle, ammonia converted to urea, and they will call the disease urea cycle disorder because urea is deficient here. Or in response to the treatment. So many pathway, they have cofactor here or vitamins as activator here. And if there is a response, they call it responsive form. If there is no response, they call it non-responsive form. However, because there is no international agreed classification, you will find like mixed classification between all these types. And I personally like what is called clinical classification. So what is clinical classification? It depends on this concept. If there is a block here, in some pathway, you will have accumulated complex molecules. In other pathway, maybe the accumulated molecule are toxic. So this may be toxic, basically in this lecture, toxic on the liver. Or in another group, there is energy deficiency. And this is happening in glycogen, glucose pathway, and fatty acid oxidation defects. So in complex molecules, if there is a deficiency here, a complex molecule accumulated, and this is example, Golgi apparatus disorder or congenital defect of glycosylation. They can present with liver problems. peroxisomal disorder, and lysosomal disorder. And the other group is the toxic group. In this toxic group, so there is small toxic molecule that are toxic on the liver. And this is happening in galactosemia or tyrosinemia and others, or in organic acidemia, or in amino acid disorder. The third group is substrate that converted to energy. So there is an energy deficiency. And what will happen here, you will find, this is example also like congenital lactic acidemia, glycogenosis defect, gluconeogenesis defect, fatty acid oxidation, and mitochondrial disorder. So I will talk about what is the presentation in every group. In the complex group, the molecule is complex, accumulated inside the liver. So you will find like progressive hepatomegaly. This is one feature. And hepatic involvement is part of systemic syndrome. So you will find liver with other systemic involvement like skeletal, cardiac, and so on. Splenomegaly is part of storage within the reticuloendothelial system. So in general, this group in general, because there is exception, there is no hepatocellular dysfunction. So there is progressive hepatomegaly, but you can look to the enzyme normal, bilirubin normal, and so on. Example of this lysosomal storage disease that include mucopolysaccharidosis, oligosaccharidosis, sphingolipidosis, mucolipidosis, and those are examples. So if you look to Haller syndrome, you will find like Haller phenotype, maybe mild, like what happened in Haller-Shy syndrome, but there is really hepatosplenomegaly, as I have said, progressive hepatomegaly without liver derangement. Another example, Hunter. You will not miss Hunter from the face. They have Haller phenotype, like thick eyebrows, bulbous nose, thick lips, but they have also hepatomegaly as part of systemic disorder. Gaucher disease, also example of this, type 1, involve the liver. Patient present with big liver and spleen, spleen usually bigger than liver, and it might involve the bone as part of storage material. So this is what happened in the liver. You will have storage material which is glucose riboside that accumulated inside the hepatocyte and inside also the Kupffer cells, which is the macrophages in the liver. Hydrops fetalis, you might consult it for this patient with this complex molecule, and it can happen because Hydrops fetalis might have hepatomegaly, ascites, and so on. So you can look for these diseases like GM1 gangliosidosis, Niemann-Pick type C, and mucopolysaccharidosis type 7. How it is progressive, just look to this concept. The disease inside it started in the utero, the onset here, and it is progressive. So by delivery, you will see patient like this. So non-immune Hydrops fetalis is with maybe with ascites and so on. If you take, as you see, abdomen filled with fluids and pleural effusion, and scrotal here, and if you take a tab, a CT tab, you send it to lab, you will see what is called vacuolated lymphocyte, or if you take blood film. So this is vacuolation. You see lymphocyte filled with vacuoles. This is not normal under blood filled. Maybe Dr. Musa will talk about this also. And if you look under microscope from bone marrow, you will see the foamy histocyte. Sometime, and this is coming to our hospital, I mean, patient come later on with this picture. And if you don't take good history that the patient presented with hydrops, non-immune Hydrops fetalis, you will miss it. Actually, many patients refer to us for consultation, and when we reviewed the history, it was like non-immune Hydrops fetalis, like what you see in this patient. He came to us later for investigation. He has some element of ascites and scrotal swelling, and final diagnosis was GM1 gangliosidosis. Peroxisomal disorder, part of this This is typical face of Zellweger syndrome. If you see the X-ray, there is punctate calcification. The patient will have hepatomegaly. They look like Down syndrome actually. But if you do the X-ray, it is not pathognomonic, but you will see the punctate calcification. If you take liver biopsy under microscope, this is normal. You will see lysosome, peroxisome. In Zellweger syndrome, you will see absent peroxisome. So I have said that the liver function is normal in this group, and there is exception. So there is liver dysfunction, and this is happening in Wolman disease, which is lysosomal storage, Gaucher disease type 3, Niemann-Pick type B and C, and peroxisomal disorder. So you will find maybe elevated liver enzyme, prolonged BTT, and other things related to liver dysfunction. This is a patient referred to us with hepatomegaly, ascites. Actually, he was in liver failure. At that time, this is long time back, during Dr. Ozan time, there was no genetic testing like now, and we took liver biopsy, which shows vacuolation also, and under microscope, you will see the cholesterol clusters in these patients, and it was proved by enzyme assay at that time to have to be Wolman disease. Niemann-Pick disease also present with CNS disease, hepatosplenomegaly. In the eye, there is cherry red macula. So also this is, you might find also abnormal function test. This is about group 1. What is about group 2? This is the toxic metabolite. So this is now, it is not the storage of material inside the cell. There is toxic metabolite that make toxicity in the liver. And they present here with hepatic failure syndrome, like what you heard about tyrosinemia case, and they can present with Ray-like syndrome. So hepatic failure, I don't want to take long time, but they presented with jaundice, hemorrhagic syndrome, elevated transaminases, and elevated INR, ascites, and edema. Example of this is fructosemia and fructose diphosphatase deficiency, galactosemia, and tyrosinemia. So this is example. This is another example. Patient presented to us with ascites, and they consult us, GI group, and we asked for urine metabolites, and it was, as I said, metabolite of galactose. I go back to the patient, I look to the eye, he had cataract, so I know this is galactosemia, proved by measuring the enzyme, and this is the same patient after galactose-free formula. So actually, if you leave the patient, he will die from liver failure. Just simple test, simple treatment, galactose-free diet, you will find different infant or child. I will not talk much about tyrosinemia. You heard about the case. Again, this is the block here, then accumulation of toxic metabolite on the liver. So what you do in treatment, you block the pathway here. So if you block the pathway by NTBC, you will avoid the accumulation of this toxic metabolites. So one presentation of the toxic group is liver failure. The other group, they present with Ray-like syndrome in the form of normal bilirubin, slightly prolonged PT, and moderately elevated transaminases. Example of this, urea cycle disorder and organic acidemia. This patient is arginosuccinic acidemia, so it is urea cycle. You will find good number of patients with hepatomegaly in this patient with non-specific reason why. Maybe because of the liver involvement in this disease, but maybe 40% or 50% of them they have liver enlargement. So far we spoke about the complex group and energy deficiency group. Now the third group, the energy deficiency here, we spoke about the complex and toxic group. Now about deficiency of energy, and basically it is related to glycogen glucose pathway or fatty acid oxidation defects. In this group, the patient might present either with hepatomegaly and with hypoglycemia, or hypoglycemia plus minus hepatomegaly, Also, they might present with Ray-like syndrome or with hepatocellular dysfunction and liver failure. So this is glycogen, this is fatty acids and phospholipid. All of them break down to acetyl-CoA, as you see. Acetyl-CoA go to Krebs cycle, and at the end you generate the energy from that pathway. Good example is glycogen storage disease. One enzyme present in lysosome and deficiency of this enzyme, alpha-1,4 glucosidase, will cause Pompe disease. This is the only enzyme in glycogen storage disease that present in the liver. The other enzyme present in cytoplasm, and as you see, glycogen break down at the end to glucose. All this breakdown related to glycogen type 4, 3, 3, and 1. So this is the liver form 2, 3, 4, and 6 also, because in 6 you have this activator, phosphorylase kinase activator. So what happened in this hypoglycemia and glycogen storage disease or fatty acid? It is due to deficiency of supply. So you have glycogen, but when you need glucose, you cannot break it down. So مستودع بس ما تقدر تستعمله، يعني مسكر الباب. Or overutilization. In fatty acid oxidation, the second line of energy is fatty acid. So if you had fatty acid oxidation defects, all the load will depend on glycogen. So there is overutilization of glycogen, and with prolonged fasting, you will see the patient with hypoglycemia. Typical example is glycogen storage disease type 1. You see this enlarged liver and early morning hypoglycemia. If you don't pick up this patient early, treat them, they might have brain insult, seizure, and developmental delay. This is the liver filled with glycogen, and this is under microscope also. Maybe Dr. Musa will tell you also some joke about this. من زمان الباثولوجيست ما كان عندهم الداي. This is glycogen. الآن عندهم الداي to dissolve this. So they put the dye, they dissolve this. من زمان ما كان عندهم الداي. So what they will do, يعني sorry to this, they spit. يعني يدفلوا في السلايد، لأن في saliva فيها amylase. فكانوا يدفلوا في السلايد وبعد كده يشوفوا إذا dissolve معناها glycogen material. The other presentation, as I have said, hepatocellular dysfunction and hepatic failure. And this is happened in LSHAD اللي هي long chain 3-hydroxy acyl CoA dehydrogenase deficiency, respiratory chain disorder, and glycogen storage disease type 3 and 4. They present with the liver failure at one point. This is a patient with the glycogen storage disease type 4. As you see, there is no treatment except liver transplantation when the patient developed or progressed to liver failure. I think we have a lot of things to be done in genetic in Saudi Arabia in all fields. لكن للأسف هذا اللي صاير. يعني this is our experience. يعني نشوف التمر أخرج النوى حط لوز، شال اللوز حط فستق. We have to change our mentality for better things يعني. If we look to the ما أدري كم باقي لي يا دكتور. دكتور؟
كم باقي دكتور بروف زهير؟
كم باقي؟ 5 10 كم باقي؟
خذ راحتك، خلص. we enjoy it صراحة، ما عندك مشكلة.
عندي هنا diagnosis in genetics. We look from the DNA to the society. So from DNA mutation, then the cell dysfunction, then the clinical presentation, then the diagnosis of the individual. Then in genetic, we have to look for the family, how to prevent the disease in other siblings. So if you see patient really in the clinic with liver involvement, you have to ask yourself, how is the liver function and what is the metabolic cause from one of the differential diagnosis. طبعا liver function, you can look to the patient. يعني is he jaundiced ولا لا. أنا I saw one patient 2 days back. طبعا ما كان معروف وش السبب لكنه 2 years old كويتي. String, he has clubbing like what that clubbing that we used to see in medicine book. يعني like the drum stick. Very typical. يعني I wish I took picture of that patient. يعني this is grade 4 clubbing or grade. You have to assess the patient. Jaundice. If you see the patient is severely jaundice, you know the color of the yellowish color, how it looks. You can say or guess this is maybe conjugated and so on. And you have to look for palmar erythema. All this is missing now in clinical exam. Look to the liver, look to the skin. Is there petechial rash or not? Don't you look for the metabolic? Examine the patient for a specific sign, like cataract. If you miss a cataract and if you see patient and he has cataract, you have to think in the top of that list, galactosemia and so on. Then after you assess the patient, you have idea, differential diagnosis, you go to the lab. So what is the aim of the lab? 2 things. First, you have to assess the degree of liver dysfunction. Is the patient mildly affected? Is he in liver failure or what? Or just hepatomegaly? You have to assess the patient, I mean from the lab, sorry, the elevated enzyme, bilirubin, and so on. So assess the liver function first. Then you look for diagnosis. Investigation of the liver function, maybe in the group in GI better than me in this, you have to look for synthetic function of the liver, looking for albumin, PT, BTT, coagulation factor, especially factor 5 and 7, and ammonia. Then you look to the test of active cell damage, which is basically the enzyme. Look to aspartate aminotransferase or alanine aminotransferase اللي هي AST and ALT. Is it mildly elevated, highly elevated, and so on. Then you look for test of cholestasis, and you look for bilirubin, conjugated or unconjugated, alkaline phosphatase, gamma trans GGT, bile acid. So you assess the function of liver from all this test. Then you go to diagnosis after the assessment. So is it you go with depends on really what you see. But this is the group of the metabolic or genetic investigation. You send tandem MS and amino acid and urinary organic acid. This is for basically the toxic group of metabolic diseases like tyrosinemia and galactosemia and so on. And also red galt transferase activity, you do it in red blood cells. Then you can assess the various lysosomal enzyme assay, and actually with the field in molecular testing, you can do this earlier than before to reach the diagnosis early and to intervene for the patient earlier than before. I found this a good way to collect urine for gas chromatography if you have difficulty. So you might find experience from your patient how they can collect urine. As you see, very simple way, but it is a good way to bring urine for GCMS. However, if you want to reach a diagnosis, this is the 3 ways to diagnose metabolic disorder. A, converted to B, B to C. So if there is enzyme deficiency here due to gene mutation, there is a block. If there is a block, B may be accumulated, A and D. If you look to A, B, and C, this is called biochemical marker. So you can send tandem MS, amino acid profile, whatever, looking for this accumulated metabolites. Or you can go to the enzyme, and this is the second way. So it is enzyme assay. Or you can go immediately to the gene, a mutated gene that form the code, the enzyme, and this is molecular genetics. So this is the only 3 ways, very simple 3 ways to diagnose metabolic disorder. Example, Heller disease. It is like deficiency of alpha iduronidase. So there is deficiency. If there is a block here, what you can see, you see accumulation of this metabolite, which is not specific here. However, you can go to the enzyme alpha iduronidase inhaler, and or you can look for the mutation. Example here is Imcad deficiency, which is fatty acid oxidation. As you know, the medium chain fatty acid goes to fatty acid oxidation to produce energy, and the enzyme coming from DNA. Again, if there is deficiency of the enzyme, accumulation of this metabolite, fatty acid with 6 carbon or 8 carbon, so you can look for this by tandem MS carnitine profile to see the elevated acyl carnitine C6 and C8, or you can look for the urine to see also dicarboxylic fatty acid, also C6 to 8, or you can go to the gene here immediately and diagnose Imcad deficiency. In Saudi Arabia, we have our diseases and our mutation. So actually, if you go to the our labs, molecular database, you will find specific mutation for Saudi patient for different diseases. For example, just cystic fibrosis, there is common mutation in the West. However, in our population, we have different 5 or 6 different mutation, not like what reported in the West. Also, this is different genes. I don't want to go more. However, this is in summary. Liver involvement is presenting feature of many inherited metabolic disorder. Hepatic presentation of inherited metabolic disorder are variable and depends on pathogenesis. The diagnosis of these diseases is crucial for early intervention and genetic counseling and prevention. لا شك أن وراء كل رجل عظيم امرأة كما تشاهدون. And just this is from the memory history, our group from GI. As you see, this is one of the early meeting in March 2012. As you see, the group Hassousa and so on, Dr. Mehedib, Lidrisi and so on. أخيرا, this is my gift. أحب الكلام إلى الله 4: سبحان الله والحمد لله ولا إله إلا الله والله أكبر لا يضرك بأيهن بدأت. Thank you very much, and I wish I can give you something from my experience in the field, and I wish it was beneficial. جزاكم الله خيرا.
Thank you very much, Prof. Zuhair. Very nice presentation, comprehensive. Really, it is informative. Everybody is enjoying your talk as usual. Really, we are glad that we have Prof. Zuhair with us tonight. Regarding the questions, if we can leave it, if you don't mind, Dr. Prof. Zuhair.
Okay, as you like.
Now we'll move to the third speaker, Dr. Musa Faqihi. Dr. Musa Faqihi is a consultant of pathology. He's trained in McGill University at Canada. He's specialized in the gastrointestinal pathology. Luckily, موسى فقيه كالغيث أنما وقع فقد نفع. Initially, he joined King Faisal Specialist Hospital when he back from Canada, and he diagnosed retrospective many cases where they were not diagnosed, especially for the chronic diarrhea patients, especially the electron microscopy. Then he moved also to King Fahd Medical City, and he did the same. He is also improved the quality of the pathology there, and also he diagnosed many cases which were not diagnosed initially. Now, and he moved to King Saud Medical City. It seems that Dr. Musa, Jazahullah Khair, he likes to diagnose all the undiagnosed cases, and يعني ينفع أو يكون كالغيث فعلا أينما ذهب نفع الله به. We are happy and we are glad that we have expert speaker with us tonight, like Dr. Musa Faqihi, to talk about the pathology from his side. Welcome, Dr. Musa, and you can start now. انميوت دكتور موسى. بالمناسبه الباثولوجيست يقال لهم وعنده جهينه الخبر واليقين يوجهني. سوي انميوت دكتور موسى تحت على اليسار الشاشه، اضغط على الكاميرا على المايك عشان الصوت. تفضل.
طيب
ايوه تفضل.
اظن شيرنج الان.
واضح.
Yes, you are sharing. It's clear now. Just put yes, clear. Go ahead.
بسم الله الرحمن الرحيم. السلام عليكم. شكرا SASPGHAN. شكرا للاخوه المنظمين. اللهم اجعلني خيرا مما يعلمون، يعني واغفر لي ما لا يعلمون مما يقولون. اشكرك على المديح الثناء، لكن لا استحق هذا كله حقيقه. انما هذا شيء من العلم، وزكاه العلم هو ان يوضع في خدمه المريض. بسم الله الرحمن الرحيم. This is some of the pathology. طبعا I will discuss the cases from pathology perspective. طبعا as my colleague have mentioned, the response of the liver to many injuries is limited حقيقة, and they may look alike. And this is why we need some ancillary studies like electron microscopy, SMS, and some genetic testing and some special stains to do some to raise some differential diagnosis of these cases. Sometime we may actually get to the correct diagnosis, but however, most of the cases we may actually generate a short list of differential diagnoses that may that will help our colleague in the GI and liver to reach the diagnosis by tailoring some more specific tests like panels, exome sequencing, and so forth, or single genes to reach the diagnosis. I'll start with one case is that it is about 1 year old, if I recall, in King Fahd Medical City, who presented with pseudointestinal obstruction. And because of his he was clinically unresponsive to the therapy, they have to deal surgery. So they have resected the segment of bowel. At the same time, I think the surgeon was clever to notice that the liver doesn't look like normal. So he took some biopsy also from the liver. And this is the picture, as you could see. There is some accumulation of the material within the hepatocytes, causing a little bit of ballooning and also rarefication of the cytoplasm. There is some material accumulated, in addition to the fat droplet, which is a round, clear substance. I hope you could see the arrow. Am I right?
دكتور موسى، ممكن في اسفل الشاشه على اليسار فيه زي البن كذا نفس العرض، انزل فيها. ممكن تختار اللون ليزر
pointer. Yeah, this one.
Yes, بالضبط. الحين واضح.
Okay, so these are hepatocytes. You can see the cytoplasm have a kind of enlarged, fluffy, granular, and there is some accentuation of the membrane. And in some of the hepatocyte, we do have some fat accumulation. This is washed with the processing. There is also some more or less of this, and you could see actually there is a fat and there is a combination of this granular substance. So this was actually in the liver. Now this is a trichrome. It's a perisinusoidal fibrosis around the hepatocyte, and some expansion of the portal tract by fibrous tissue. And also a gallbladder was also taken out, and I think you can see the same material also deposited in the parenchyma of the gallbladder wall. This is the funny part. It has some same appearance within the lamina propria of the bowel. So and also it is actually accumulated within the ganglion cells between the two muscles. So I think this although at that time we didn't have a molecular diagnosis, this is one of the glycoprotein or mucopolysaccharidases cases. So this is a very funny kind of presentation, just to trigger the thinking of this case, about this case, although we didn't have a definite diagnosis at that time. Now, we move on to the most common one that encountered by the pathologist. As my colleague, Professor Zuhair, have mentioned that glycogen storage disease, especially type 1, is common. and we used to have it not as common as in the previous previous years. Nowadays, with the presence of some genetic studies, tend to decrease. But nevertheless, if you plan to have a core biopsy of glycogen storage disease, depicted in the picture are some of the features. So we have an accentuation again of the periphery of the cytoplasm, that is the membrane, and accumulation of this very pale material inside. And sometimes you would be also seeing an intranuclear glycogen. So this is in general will hint to glycogen storage disease, which what we call it is actually it's like the يعني خلية النباتية. So the الخلية النباتية is characterized by accentuation of the cell membrane with lucency of the cytoplasm, and this is related to the accumulation of the glycogen and also some metabolite inside the hepatocyte. This is low power view, this high power view. If we go into much more larger cells, you'll see, especially in type 1 glycogen storage disease, a lot of fat, which are these kind of rounded structure, and sometimes maybe really very severe. So this is the second case. It was 5-month-old baby who presented with recurrent bouts of hypoglycemia, hepatomegaly, very classic. يعني. So combination of this. طبعا segregation of glycogen storage disease from each other. It is something sometime we could make it, especially if we have, unfortunately, I didn't have a picture. Like in type 2 and type 4, they have ultra-structural features that are more specific toward that. I think, mashallah, Dr. Zuhair and all the molecular pathologists now have taken the era, so it's much easier diagnosed by molecular pathology than ultra-structural feature. But at least we could say, okay, you know, it is not Gaucher disease, it's most likely glycogen storage disease. You have to look for the one that is affecting the liver, type 1, type 3, 6, 9, 2, and 4, and so forth. This is one of the cases. This is actually not from my collection. It came as a, this is an adult, not a pediatric. I haven't seen a case actually. There was also always a suspicion of this alpha-1 antitrypsin. But nevertheless, if we have a biopsy in early age, usually it doesn't actually have this classical feature. This is a cirrhotic liver, very progressive. There is a lot of nodules here, and you can see they appear as positive droplets, especially at the periphery of these nodules. Going into high magnification will easily pick up this small droplets, and if you have more and more magnification, you would be seeing these droplets at the periphery of the nodules much more easily. I would like to say that alpha-1 antitrypsin, I think it is very rare. Honestly, I haven't seen a single case, although I has been sensitized to many cases like that. Wilson disease. Just last case, I get a call from our colleague who was sending me a case thinking of Wilson disease. And then I told him, oh, no, nada, this is not the case. In this picture, this is a 10-year-old boy with neurological disorder. I think it is from King Fahd Medical City. So it's in general, it's a hepatic picture with some with some giant cell transformation. And it depends on the stage where it picks up. Sometimes it's very severe, very progressive, with a lot of giant cell transformation and fibrosis, progressive fibrosis. In this case, we have a little bit of fibrosis at the periphery, maybe here, and some ballooning of the cytoplasm due to the accumulation of the toxic metabolites. Okay, now Dr. Zuhair have mentioned so many cases of cholestasis in children, and I would like to mention, just go over the progressive familial intrahepatic cholestasis because they are actually, these are the most common cases that I have seen. Some cases of bile acid sensitive defect is part of the differential diagnosis, and also we have to differentiate between the one that looks like metabolic, but they are not metabolic, Alagille syndrome, sclerosing cholangitis, neonatal, of course, and pediatric. it's really very, very critical to differentiate biliary atresia, especially when it comes to Bific type 3. Although now here I have to mention it very clearly. Now, in clinical sense, it doesn't make any sense to differentiate between Bific type 3 and biliary atresia. But as a pathologist, if we are living at the territory and in a very specialized center, and I get a consultation from the periphery, there is no age, there's nothing, and just a piece of slide, and you have to make a judgment, and then it will be really difficult to differentiate Bific type 3 from biliary atresia. We're going to come to that in a second. So biliary atresia, extrahepatic biliary atresia, very well known, very progressive. Usually within 3 months, the child will have a fibrosis, nodular cirrhosis, and regenerative nodules with a lot of bile duct proliferation, some edema, and also canalicular and also ductular cholestasis. Some giant cell transformation may also exist, and accompanying chronic inflammation as a matter of they are attending there. Bile lake may be also there, and as we said, within three months it will progress to more and more and become cirrhotic. Large bile duct becoming speciated with bile, and then the bile ductules may decrease in number progressively. And the treatment of that, it has to be picked up very early in order to go for Kasai aberration. Now, moving to the progressive familial intrahepatic cholestasis, this is a nice article that has been done by, I think, Dr. Kuraya and his group and Dr. Ali from King Faisal. So they actually gathered so many cases of Bific, and they're trying to triage the cases according to some clinical parameters. Those who have a lower or normal GGT cholestasis, you would think about normal bile acid for bile acid synthesis defect if the patient have normal bile acids. If the patient have a high serum bile acid, the differential diagnosis will be there in the left. As you can see, it could be Bific type 1, type 2, and so forth. And also some special attention to microvillus disease in addition to liver disease. Now, if the gamma GT is high, then you have to think about other differential diagnoses. And as I said, biliary atresia is one of the top. And then Bific type 3, choledochal cyst, and Carolase disease. Now, let's us move to Bific type 3. It's a very progressive, followed by duct proliferation, associated with significant fibrosis and cholestasis as well. And there is accompanying inflammation as well in the portal tract and some giant cell transformation. If you do a trichrome stain, you will see the start of bridging fibrosis, and this will rapidly progress to cirrhosis. This is the H&E on the left-hand side, and this is a trichrome stain. Sorry for the type error in the trichrome. This is H&E, not trichrome. So this is, if you give me as a pathologist a slide of this patient and say, could you tell if this is biliary cirrhosis, this is biliary atresia or Bific type 3, it would be really difficult. Of course, the edema maybe, and also the specific bile at this stage may help, but it can't really give a 100 diagnosis segregation between the two. Now, some pathologists may have a good facility to do MDR immunohistochemistry. This is normal staining of the MDR. So if it is absent, it means abnormal. If it is present, that means the enzyme is there. So you may have it as an absence of the staining to call it, okay, this is consistent with Bific type 3. If otherwise the histopathological feature is done. Now moving on to Bific type 2, which is the most common actually, you will have some feature more common to Bific type 3. So you have a giant cell transformation of the hepatocyte and lobular disarray, with also portal expansion and progress to fibrosis, with progressive fibrosis, and sometimes it's associated with canalicular cholestasis. In this picture, this is from my collection, you can see that there's some xenophils, a little bit of edema, giant cell transformation. Some of the hepatocytes contain more than 5 nuclei and even more. and ballooning also as well. So that is what we call this liver disarray. So it is a progressive, okay? Now, BSEP immunohistochemistry, it may be helpful. If it is negative, then the case is suspected to have Bific type 2. If it is normal, it should be present as a brown granules, as we have seen. Its sensitivity is up to 84% in the cases. This is from Al-Gindi collection. So the trichrome stain is not as progressive as actually Bific type 3, but nevertheless, there is perisinusoidal fibrosis and also expansion of the portal tract as well. So this is actually the genetic study of this case, the last case. So this was actually confirmed by doing exome sequencing, and you could see the genotype here is both alleles are affected, and the diagnosis was hinged. So it's very good. So when we speak to our colleagues, we're trying to segregate according to the clinical feature, trying to triage it. So I get the question: is this biliary atresia? The answer is less likely. So could you triage it into any specific category? Because yes, I have to see the gamma GT and other parameters in addition to the clinical suspicion. So okay, well, this maybe most likely Bific type 2 or 3, and in addition to other differential diagnoses that may include bile acid synthesis defect. This is another case also, some more or less the same morphological feature. I don't have to repeat, I guess. So no real interface activity, some residual inflammatory infiltrate within the portal area. And again, this is also has been diagnosed as Bific type 2. I think we have done a study with Dr. Abdurrahman Husseini. I think the most common disease entity is Bific type 2. If you compare it with other Bific, progressive familial intrahepatic cholestasis, type 2 is the most common. And this is the genetic study that has been done for this patient. What about Bific type 2? Okay, this is totally different story. At low power, you could see there is no much you could see. Maybe there is some cholestasis, which is not apparent from this power. There is no liver disarray, and maybe some portal expansion. Well, could be. No giant cell transformation that actually seen at this power. Now, high power, this asterisk is supposed to show, sorry for that, it should be high power, like cholestasis, one here and one here. I hope this is clear. There is some rounded brown structure depicting canalicular cholestasis. That's all what we see in this case. And a little bit of fibrosis maybe in the portal tract, but that was nothing to compare with type 2 or type 3. And then genetic studies, when we say that this is okay, progressive familial intrahepatic cholestasis, type 1, both genes get affected. So this seems to, at pathological features, is a little bit less aggressive as compared to the other. Okay, now we're still in the liver, although the picture is from the GI. Now, what about those patients who have a cholestasis and some GI manifestation? Okay, well, this case, which have actually some sort of vacuoles at the surface of the epithelium of the duodenum, along with a liver biopsy was done for the same patient, and it shows, well, nothing really much, bile ductules here, some giant cell transformation, maybe cholestasis, which is here. Sorry, my picture is so small. So cholestasis is a little bit of bile duct perforation and some fibrosis, and there is some inclusion. Okay. This is again, I think I just took the picture, and maybe some of the bile duct here is not apparent, and a little bit of fibrosis. So this is actually the same patient, fibrosis here. So here as well, and some canalicular, pericanalicular fibrosis. So these cases, I think we have two cases, and this is what we call it locus myo5B in addition to other, and this is, I think, it called DIAR too. I think the diagnosis, clinical diagnosis of DIAR. So far, I have two diagnoses. By the way, this is a enterocyte from the small bowel or duodenum, and you can see these are the microvilli with rotlets here, and these are inclusion, microvillus inclusion. And you can see these are the microvilli, and they have rotlets insertion inside the cytoplasm to fix them. So this is very typical of inclusion in this case. So that's what we call DIAR2. Just a very quick review. I think Dr. Zahir have mentioned that MDR3, Bific Type 3, this is Bific Type 2, and number 1 also. So this is actually the cascade and the representation of the proteins that are involved in bile acid, bile flow actually in the hepatocyte, not flow. And these are actually the synthesis. So any block in here may actually give you a lot of manifestations that sometimes very difficult to isolate each one from the other. This is also one of the cases that I have reviewed. And I wasn't really, to be honest, I wasn't really able to make the diagnosis from the first time. It posed a lot of challenge. To me, it looks like, well, this could be Bific Type 1. And actually, this is a very valid differential diagnosis. And I will say it again, because some of you may have really get surprised. Now I'm looking to these cases as if I have no idea about the clinical scenario. Okay, so these are bile ducts or ductules, which is normal, no proliferation, very little inflammation, a little bit of expansion, and the lobular architecture is totally maintained. So this is a benign, not a benign, but a less progressive form of metabolic liver disease. And as you can see in the screen, this is called 3-beta hydroxy delta 5 C25 steroid oxidoreductase deficiency. Okay, so it is some of these diseases of bile acid synthesis. I think we have more, as you can see here in these pathways. There is a lot, and some of these diseases yet to see are very aggressive and may actually look like a Bific Type 2 or 3. This is actually some of the other, a little bit more aggressive actually. See, this is beta reductase deficiency. There's a lot of fibrosis, a lot of inflammation. This is actually from the internet, not from my collection. So just again, to wrap it, so according to them, they have found 16 cases of Bific Type 3, but 27 cases of Bific Type 2 and 5 cases, they were able to segregate the cases according to the scheme that they propose. So this is just to compare one-to-one. This is by Bific Type 3 or 2. This is most likely Bific Type 3, and this is extrahepatic biliary atresia. You know, at some extent, there's some similarities. However, there's an extensive edema here that actually may differentiate extrahepatic biliary atresia from Bific Type 3, which is actually coming at more advanced age, at 1 year and a half. But just to keep in mind the pattern. And fibrosis, this is definitely almost like getting to stage 3 to 4, but this is maybe stage 2 at age of 1.5 year. So this is the clinical scenario is very critical in making some of these differential diagnoses. Bific Type 2, neonatal sclerosing cholangitis, a little bit of edema here. Some bile ductules here get damaged, cholangiopathy. As compared to this one, I think this is this one has no lobular disarray, and there is no giant cell transformation. And the contrast here is giant cell transformation. Also, I couldn't really see the bile duct, but you will see maybe bile duct proliferation a little bit. So also when you have something like not that aggressive, but still you see some fibrosis, think of this Bific Type 2, neonatal sclerosing cholangitis, try to correlate other manifestation or other clinical parameters. And again, Bific Type 1 is, in this case, it looks like really nothing to worry about at low power, however. And 3-beta is bile acid sensitive defect. You know, if you could change the picture between the two, and I can't really segregate this from that. So this is a very valid differential diagnosis if you are blinded completely to the clinical manifestations and history. So this is what I want to say. Yeah, a few messages. So the liver has a limited response to injuries. Always we have to think about the clinical manifestation in addition to the laboratory finding in order to put all these informations together. The main purpose of the liver biopsy is actually to exclude some of the potentially treatable condition, extrahepatic biliary atresia, which is top of the list, and the reliability of the diagnosis may reach up to 85% to 90% based on liver biopsies. That's what I want to say. Thank you very much.
Thank you so much, Dr. Musa, for this nice presentation. We have just, we'll select one question for each. First of all, for Dr. Dhafir, they ask about your patient, the Terracinemia, that child survive and how the survival rate for those patients.
Actually, the survival rate is good if they diagnose him early and prevent further damage of the liver and the kidneys. Based on the restriction diet and also NTBC medication. Actually, there is a number, the complications of hepatocellular carcinoma is still there, okay, but it should monitor the patient regularly. As I mentioned, regarding alpha-fetoprotein, it should be monitored every 6 to 12 months. Also, ultrasound abdomen, it should be done annually, okay? To see if there is any nodules that is precursors of liver damage. Also, the eye manifestations or the eye examinations, it should also be done annually to prevent side effect of the medication. So overall, the prognosis is acceptable and good if the patient treated early.
Okay, thank you, Dr. Dhafir. Professor Zuhair, there is a question regarding the gene therapy. Is it available, and if it's used, for how long?
Thank you very much. Gene therapy, طبعا, this is it will come for many diseases, especially for metabolic. But it's still in experimental stage, clinical stage. For many diseases, I am not sure if Terracinemia included. I have to check. لأنه correction with gene therapy in metabolic diseases is easier. You can inject the gene in the liver that correct the enzyme. So if you reach this point, the problem with all gene therapy now, two problems. أول شيء, the safety of the viruses is still, they want to make sure that it is safe, and there is no other side effects from gene therapy. The second thing, they want to give gene therapy and maintain the treatment. They don't want to give therapy, gene therapy every few days. They should inject the gene and correct the problem to be like permanent. So if they solve all these issues in gene therapy, I think it will come. And I am sure this is in next decade or in few years, I am sure it will come for many metabolic diseases. طبعا الآن في الجين ثيرابي بعض الجينetics مثل بعض الأنواع الريتينايتس بيجمنتوزا. الآن في الجين ثيرابي to inject the gene inside the retina and correct the problem for retinitis pigmentosa one type. And also it is coming for sickle cell الآن بعض الأشياء. I am sure this is I can say the century of gene therapy. طبعا I don't know how long we will see this, لكن I am sure this century is the century of gene therapy. Like last century, I call it the century to treat infectious disease. last century is كان foundation of antibiotic والvaccination. So it was the century of infectious disease. This century اللي هو 2000 إلى 2100 الله أعلم. لكن this is the century of gene therapy.
Okay, مشكور دكتور زهير, Prof. Zuhair. Question for Dr. Musa and maybe Dr. Zuhair regarding the difference between now with the era of genetics now. Is there any difference between some cases diagnosed by histopathology as a pathologist from your side and they found same or different, diagnosis genetically? Maybe
أنا ممكن أبدأ لأني أعطيك الهيستوري شوية. طبعا نحن from we started my training in metabolic genetics since early 90s. At that time, we used to do a lot of liver biopsies. يعني most of our patients, they and we give يعني fresh frozen plasma عشان أحيانا عنده liver dysfunction وكذا. And we go with liver, and we go with the enzyme say مثلا glycogen storage disease for the liver والأشياء هذه. طبعا with the technology in molecular pathology, we are rarely now doing يعني liver biopsy. Really, except for what I call it functional study. يعني we have a patient with VOS, and it might be the cause, the pathology or not. So we go sometime with more invasive liver biopsy. لكن I don't know now يعني الدكتور ممكن الدكتور
موسى
يعني يعلق على الاكسبيرينس of biopsy now يعني.
Sure. طبعا true. Liver biopsy was previously was one of the cornerstone of diagnosing, or at least raising the differential diagnosing, helping the geneticist, our gastroenterologist, to treat the patient and reach a diagnosis. طبعا nowadays طبعا it is invasive. It has a lot of you have to prepare the patient, you have to do a lot of things طبعا. And it has its own major risk. لكن في وجود a new era of genetics, exome, genomes, panels, single genes, I think now, yes, true. حتى electron microscopy, not only the genes, it tend to decrease much more less than before حقيقة. And now we are seeing some of the cases that is related to the function of Dr. Zain. This is true. And this is really healthy. هي في محصلة الأمر, you want to reach a diagnosis as fast as possible, as safe as possible, and intervene as requested to reach a diagnosis and to recover a patient. Agree.
Thank you so much. By the end, I would like to thank our speakers for this webinar, and also regarding the questions of the attendees regarding the CMIS hours, there is a message from the SASPGHAN. Please just answer the survey or reply to the survey, and you'll get the CMIS hour. It is accredited by 3 CMIS hours tonight. Thank you again, Professor Zahir, Dr. Musa, Dr. Dhafir, for this really nice webinar. And we are happy and glad in SASPGHAN to have such speakers like you. Thank you so much. See you inshallah soon inshallah. جزاكم الله خير.
شكرا على الاستضافة. شكرا جزاكم الله خير. السلام عليكم.
دكتور ظافر.
Before we are closing, there is a webinar tomorrow for the public. I will show it now to you. مخاطر المواد الحارقة على الأطفال. I hope if you have patience, and also all of us, we have children, so it's nice to invite your patients and your relatives to this webinar tomorrow, inshallah, at 8:30.
In Arabic language, Dr. Dhafir.
أنا أرسلت التغريدة موجود فيها رابط الدخول في الشات الحين.
بيطلع عندنا ولا صعبة؟
الشات برسله في الشات رابط التغريدة.
اوكي.
هذا هو. الله يعطيكم العافية جميعا. الله يقدك سمو سارة. شكرا.
أبو عبد العزيز جزاك الله خير. كيف الأمور؟ ظافر؟